Welcome back. In today's video, we are going to discuss about Meniere's disease. Meniere's disease is also known as idiopathic endolymphatic hydrops. Prosper Miniere first described this disorder in 1861. People suffering with Meniere's disease will present with spontaneous episodic vertigo, the vertigo which is coming in episodes, fluctuating sensorineural hearing loss. They have hearing loss which is sensorineural type and it is fluctuating. Tinnitus, it is a roaring or ringing sound in the ears. Sensation of fluctuating earfulness. So people with Meniere's disease will present with vertigo, hearing loss, tinnitus and earfulness. The incidence of Meniere's disease, it varies from 7.5 to 157% in 1 lakh persons. It will affect primarily the Caucasians with a slight female preponderance. So Caucasians are more affected and incidence is more found in females into a slight extent. About 10% of the dizziness patients will have Meniere's. So people diagnosed with dizziness who are suffering with the dizziness will out of those people suffering with dizziness, 10% will suffer from Meniere's disease. The age of onset of the Meniere's disease is 4 to 90 years, but the peak of the Meniere's disease is in 40 to 60 years age group. So old age 40 to 60 people have Meniere's disease. Bilateral disease will develop in 47% of the cases. It is followed up for 20 years. Etiology. The exact cause of the Meniere's disease is not yet known. The theories which propose the causes are viral, the causative role of the virus, HSV, cytomegalovirus or VZV remain uncertain. Whereas the hereditary cause like the familial occurrences is found in about 10 to 20% cases, there is an autosomal dominant mode of inheritance. Okay, it could be either viral or hereditary. In 10 to 20% cases it is hereditary and it is autosomal dominant. Autoimmune causes certain genetically acquired major histocompatibility complexes. The histocompatibility complexes, specifically the human leukocyte antigens that is HLA, B8 or DR3 and CW7 have been associated with the Meniere's disease. The pathogenesis of Meniere's disease. Before understanding the pathogenesis, we need to know the anatomy of the ear. We have the outer ear with the external auditory canal, then the middle ear with the tympanic membrane and auditory ossicles, and the inner ear main focus have to be on this. We have the oval window, round window, cochlea and the vestibular apparatus comprising the semicircular canals vestibule, together forming the vestibular apparatus and the vestibulocochlear nerve. Now, the inner ear has two main components, that is bony labyrinth and membranous labyrinth. The bony labyrinth will consist the bony cavities within the petrous part of the temporal bone. Okay, it is comprising of the cochlea, vestibule and semicircular canals. You see this cochlea, the vestibule and the semicircular canals. They have two openings, oval window, round window. Then we see that the bony labyrinth, all these structures are lined internally with the periosteum and they will contain the fluid perilymph. So we saw in the bony labyrinth we have perilymph. Okay, these fluids are very important, you have to remember. The perilymph will be found. Then we have the membranous labyrinth. The membranous labyrinth will lie within the bony labyrinth. Within this bony labyrinth lies the membranous labyrinth. They contain the cochlear duct. You can see this. This is the cochlea and the cochlear duct which is lying within the membranous duct. Within the bony is the membranous. Okay, we have the cochlear duct, the utricle, saccule. Then we also have the semicircular ducts. The membranous labyrinth is filled with endolymph. So guys, you can see here clearly we have the bony labyrinth. Within this bony labyrinth we have the first comes the bony labyrinth. Okay, within this bony labyrinth this thing is is the membranous labyrinth. It is containing the cochlear duct, okay, utricle, saccule, and also the semicircular duct. Now we move on to this part, that is cochlea. What happens in this cochlea? The cochlea will be made up with the three compartments. We can see the three compartments here: the scala tympani, scala media, and scala vestibuli. Okay, all these three are separated from each other by two membranes. Now you saw the three compartments here. This cochlear cross section, you're taking a part of the cochlea with its cross section. You can see the three compartments, tympani, media, and vestibuli. These three compartments are going to be separated by the two membranes. The two membranes are the basilar membrane and the Reissner's membrane. So you can see the basilar membrane and the Reissner's membrane, which is separating these three cavities. The same are mentioned here, okay. The membranes I'm showing you, the scala tympani, media, and vestibuli. Now we have two membranes, the basilar membrane and the Reissner's membrane, okay. Now we also have the two openings. The openings are the round window or oval window. They'll be covered with the membranes. Both are covered with the membranes, okay. Now, between the outer wall of the membranous labyrinth and the wall of the bony labyrinth is the perilymphatic space, and it will contain the perilymph. Now, we saw that between the outer wall of the membranous labyrinth, this membranous labyrinth, the outer wall, and between the bony labyrinth, we have the perilymph, which is containing perilymphatic space, which is containing the perilymph. So, we have understood the anatomy properly. So now when you go to the pathogenesis, you can relate on which parts and or the which parts of the ear are affected. Now there is ischemia, that is reduced blood supply, and fibrosis. Fibrosis is the scarring. It is leading to the inadequate absorption of the endolymph by the endolymphatic sac. So guys, you can see the endolymphatic sac here. This sac, endolymphatic sac, because of the ischemia, and there is an inadequate absorption of and the fibrosis. This ischemia and the fibrosis, the scarring, it is leading to the inadequate absorption of the endolymph by the endolymphatic sac. As a result, there is over accumulation of the endolymph in the perilymphatic space. This results in the distortion of the membranous labyrinth. So guys, you can see here, whenever there is more accumulation of the endolymphatic, then it will lead to a distortion in the adjacent site, which is nothing but the membranous labyrinth. Alterations in the size of the endolymphatic duct and the sac. So you can see there is an alteration in the endolymphatic duct, and also the sac is also altered. Because of the alterations in the sac as well as the duct, there is a reduction in the tubular specializations of the lining of these structures. The specializations which are present in the lining of the structures are also being reduced, okay. What's happening guys, in the pathogenesis we saw there is ischemia, there is fibrosis, inadequate absorption of the endolymph. Then as a result, whenever there is inadequate absorption, what happens? Obviously there will be over accumulation. This over accumulation is distorting the membranous labyrinth. Now you can see here, this is a normal endolymph which is absorbed, okay. Now here there is a reduction in the absorption, then over accumulation. It is distorting the membranous labyrinth, okay. The basilar membrane gets distended into the scala tympani. So guys, you know, I showed you in the picture the scala tympani. Now what's happening? The basilar membrane is extending. Now you see here, this basilar membrane, it is extending into the scala tympani. Then what happens? Once the basilar membrane is distended into the scala tympani, what happens? Okay, see, the basilar membrane, it is extending into the scala tympani. Because of this extension, the saccular distension can not only, then there is saccular distension. Then the saccular distension, it is not only distorting the utricle, but also it will come in contact with the stapes of the foot plate. This can cause the Henneberg sign, okay. So guys, there is distension into the scala tympani, then there is saccular distension, which is not only distorting the adjacent utricle but also coming with the steps of the foot plate. Okay. Pathogenesis, then continuation, the hair cells and the neurons are usually spared. Now in this picture we can see the hair cells. These are the outer hair cells and the nerve cells. All these are usually spared in the Meniere's disease. More is in the endolymphatic sac. Okay. And then the membranous rupture, which can also occur in any part of the inner ear, will allow the leakage. So you can see the inner ear whenever there is a membranous rupture. So what's happening? Inadequate absorption, over accumulation. Because of the over accumulation, rupture can occur. This rupture it can occur in any part of the inner ear. It could be the sac or the duct, or then we have the saccule, utricle. In any part of these inner ears, if there is some rupture, it will allow the leakage of the potassium rich endolymph into the perilymph. So we see that then from the endolymph the fluid is entering into the perilymph. Healing of the membrane will allow the restitution of the normal chemical and the clinical status. So whenever the membrane is healed up, then what happens? It comes back to the normal state. Clinical features. Typical presentation will consist of recurring attacks. Okay, they're talking about the vertigo attacks here. The vertigo attacks, they are about 3 to 11 per year. There is spinning vertigo in about 96.2%. Okay, and the vertigo attacks will stay from few minutes to hours. Vertigo attacks are preceded by an aura. So first there is a feeling, okay, feeling of there is some discomfort. It is preceded by an aura. What does this aura comprise of? There is fullness in the ear, increasing tinnitus, decreasing in hearing. Attacks may be sudden. So guys, you can see here there is vertigo. Okay, before the vertigo there is fullness in the ear. First thing, there is fullness. Then they also have the increasing tinnitus. There is a ringing sound in the ear. Whenever the ringing sound increases, obviously the hearing will decrease. Then the attacks are sudden. The attacks will cease spontaneously after the 2 years. So person having the Meniere's attack, spontaneously after the 2 years, these attacks are going to cease in them. Attacks are often accompanied by nausea, vomiting, diarrhea and sweating. Along with the attacks, patient suffers from nausea, vomiting, diarrhea and sweating. Between the attacks, okay, now once an attack comes and another attack, the time period between the two attacks is totally symptom free. Or there could be some side effects like disequilibrium, lightheadedness or a slight tilt can be felt in the patient. Hearing loss is fluctuating and progressive. So we are done with the vertigo attacks. In vertigo, you have to remember there is 3 to 11 per year and there is aura. Aura will consist of fullness in the ear, tinnitus, decreased hearing. Then attacks will cease after 2 years. There is accompanying of attacks with nausea, vomiting, diarrhea and sweating. Then the patient is symptom free during the period of attacks and there is disequilibrium, tilt found. Okay. Now the second point, vertigo attacks are done. Then we saw the sensorineural hearing loss. Hearing loss is fluctuating and it is going to be progressive. Diplacusis, a difference in the perception of the pitch between the ears. So what is diplacusis? Diplacusis is what? Whenever there is a difference in the perception of the pitch. It is between the ears. One ear they can hear the high pitch and the other one low pitch. So there is a difference in the perception of the pitch between the two ears, and the recruitment, that is intolerance to the loud sounds, may be present. Tinnitus is non-pulsatile. So we are done with sensory neural hearing loss. Next point was tinnitus. How was the tinnitus in the patient? It is non-pulsatile. It may be whistling, roaring, continuous or intermittent. Differential diagnosis for the Meniere's disease. Meniere's disease is an idiopathic lesion. Which is an idiopathic lesion. It is a clinical diagnosis. Okay, based on the symptoms and signs you have to diagnose. No pathological abnormality much they don't observe. Okay, the following conditions just from outside. So you see that clinical diagnosis is more prominent here. Following conditions which are included in the Miniere syndrome: migraine and basilar migraine. So it could be migraine or basilar migraine, Autoimmune diseases of inner ear and otosclerosis. So they are talking about the autoimmune diseases of the inner ears. And otosclerosis, the otosclerosis is nothing but the hardening of the ear. It is resulting from the formation of an abnormal spongy bone. This bone like growth is along the stapes of the middle ear. Okay. Then a trauma, head injury or the ear surgery, acoustic neuroma. Then the surgery for the acoustic neuroma, it is performed under the general anesthesia. What do we do in the acoustic neuroma? It is removing the tumor through the inner ear. It is through the window they go into in your skull, and then they remove the tumor. Okay, this is about the, then you can see the picture here. This is a surgery, acoustic neuroma surgery. It can be a differential diagnosis for Meniere's disease. Vertebral basilar insufficiency. So vertebral basilar insufficiency, it is nothing but the poor blood flow to the posterior portion of the brain. The posterior portion of the brain is usually fed by the two vertebral arteries. They join to become the basilar artery. So you can see the two vertebral arteries joining to become the basilar artery, and then whenever there is a poor blood supply to this basilar artery, can result in basilar insufficiency. Then we have the Cognan syndrome. Coggan syndrome is characterized by the recurrent ocular inflammation. So the eyes, okay, ocular inflammation as well as the hearing loss. It can lead to deafness if it is left untreated. Okay. The investigations performed are glycerol test. Ingestion of the glycerin 1.5 ml per kg of the person's body weight. So you take a glycerin about 1.5 ml. In proportions to the body weight. Okay, the person, if he is 30 kg, 1.5 into 30. Okay, based on the person's weight, you're taking 1.5 ml per kg of the body weight, and it is mixed with the equal volume of saline. This glycerin is mixed with equal volumes of saline, and it is followed by the serial audiograms over the 3 hours. Then the positive test, you see the 25 dB shift at the 3 consecutive frequencies, or 16% improvement in the speech discrimination can be observed. The dehydrating agents like the urea, glycerol, furosemide produce the measurable improvement in audiometric score. So guys, you can see they are talking about the audiogram here. Audiogram is nothing but a graph. It will show the audible threshold for the standardized frequencies, which is measured by a audiometer. You, with the help of the audiometer, you are measuring the frequencies, and then this will produce a graph. Okay, with the help of the graph, you can make out the improvement in the patient. Then what do you see here? 25 dB shift you can see in the graph at the 3 consecutive frequencies. Then the dehydrating agents will also help. Electron seismography, the caloric response is significantly reduced here. Then the complete loss is occurring in about 6 to 11% cases. Following findings may be seen. The CT scan, when you do the CT scan, you can see the hypoplasia of the endolymphatic sac and duct. So you can see the endolymphatic sac, this endolymphatic sac and the duct, there is hypoplasia. Okay, it is becoming this small. And then MRI, it will show the smaller and shorter endolymphatic drainage system. Again, this is smaller and shorter. The gadolinium enhanced MRI. So during the MRI, you inject the gadolinium, right? So this gadolinium enhancement of the endolymphatic sac will reflect the inflammation of the sac. In this MRI, you can see the inflammations of the sac. Electrocochleography. Submitting potential, it is larger and more negative due to the distension of the basilar membrane into the scala tympani. We saw that the basilar membrane, the basilar membrane, it is extending into the scala tympani. Because of the distension of the basilar membrane into the scala tympani, we can see a larger and more negative submitting potential in the cochleography. Okay. Then the medical treatment for the Meniere's disease, there is no curative therapy for the Meniere's disease. Conservative measurements are taken. The general measures, what you have to tell to the patients are, give them reassurance, explain them the nature of the disease, and that explanation can relieve the anxiety in the patient. It will help a lot. So you have to explain the patient their disease. And then the lifestyle changes should be advised. If they are on smoking, ask them to stop the smoking, cessation of the smoking. They should avoid the excess intake of water and salt, avoid too much tea, coffee and alcohol, avoid the stress. They should practice the mental relaxation, exercise, meditation and yoga, avoid flying, diving, working at a greater heights to prevent the accident in case of sudden episodes. In case of acute attack, vestibular sedatives will be helpful. They have to be given either parenterally if the vomiting is precludes the oral use. Okay, if oral use is not possible, give them sedatives, which is parenteral if oral route is not possible because of the episodes of vomiting. They can take care of the vertigo and anxiety and include the prochloroperazine, that is Stemetil, promethazine thioclate, Avomin, and dimenhydrinate, that is Dramamine, and diazepam. Atropine can also be effective. So whenever there is vestibular sedatives given, and then for the vomiting and everything, vertigo, anxiety and vomiting, we can give them Avomin, Stemetil, Dramamine and diazepam. Now you can see the tablets here: Stemetil tablet, Dramamine, Avomin. Okay, the diazepam injection and atropine can also be useful. Then vasodilators, the inhalation of carbogen, that is 5% carbon dioxide with the 95% of the oxygen, it will cause the cerebral vasodilation and it will improve the labyrinthine circulation. It will improve the circulation. Histamine diphosphate 2.75 mg in 500 ml glucose, slowly IV drip have to be given. Okay, in 500 ml of glucose, add histamine diphosphate. It will help in managing the acute episodes, but it is contraindicated in the asthmatics and it should not be given in empty stomach and should not be given to the asthmatic people. The adverse side effects of the histamine diphosphate will include the tachycardia, disturbed cardiac rhythm, hypotension, hyperrhythmia and bronchospasm. In case of a chronic case, in chronic stages, chronic phases, we have to think of the dietary modifications, the salt restriction, intermittent dehydration, hyperosmolar dehydration and diuretics. So guys, the salt reduction and dehydration has to be done so that the fluid content is brought down. Hyperosmotic diuretic isosorbide, acetozolamide, carbonic anhydrate inhibitors, furosemide 40 mg. You can see furosemide Lasix. It is 40 mg on alternate day with the potassium supplement will help in some cases. So we also have acetazolamide tablets, azetamide tablets and furosemide. Symptomatic medications, they are beneficial in reducing the symptoms and in improving the tolerance. Anti-vertiginous, anti-emetics. So see, they have vertigo, so give them anti-vertiginous, emetics, vomiting, so anti-emetics, sedatives, antidepressants and psychiatric treatment. Elimination of the allergen. In case of the allergy, the causative allergen should be eliminated. So if there is an allergen, you have to find out the cause, which type of allergen is present, and ask the patient to eliminate the allergen so that there are no recurrent attacks. Hormones, endocrinal hypofunctioning such as hypothyroidism. The hypothyroidism needs a appropriate replacement therapy. The other therapies will include the acupuncture, herbal remedies. Surgical treatment. Hearing conservative non-vestibular ablative surgery. Cochleosacculotomy, when the mechanical blockage of the utricle and saccular ducts does not allow the endolymph to reach the endolymphatic sac, then the perforation of the saccule is done behind the oval window with a pick to the round window. So guys, you can see here, this is the saccule. So what they are doing to the saccule, when the utricle and the saccule ducts, so when the ducts are being blocked, and it is not allowing the endolymph to reach the endolymphatic sac. We saw there is endolymphatic duct and endolymphatic sac. Then the blockage is there. So you have to perforate the saccule, and then the perforation is done behind the oval window through the round window. Going through the round window, behind the oval window, we are going to perforate the saccule and remove the blockage so that the endolymph can go into the endolymphatic sac. Okay. Fick and Kodiak procedures, they will create the fistulas in the saccule. Again, an abnormal communication has been created between the saccule and the oval window so that the fluid can come out. Okay, they will create the fistulas in saccule and oval window. Vestibular neurectomy, about 95% of the patients have the complete resolution of vertigo in case of vestibular neurectomy. Intratympanic injections of aminoglycoside. Streptomycin, it's not being used now because of the high risk of HL. And gentamicin, annular vestibulo-ocular reflex, the rapid head thrust is seen. In case of the rapid head thrust, gentamicin is used. Cryosurgery, ultrasound, cochlear dialysis, cochlear implantation when bilateral, severe to profound hearing loss is found. So guys, you can see whenever the hearing loss is bilateral, then we do the cochlear implantation. The cochlea is now completely gone, so we need a artificial cochlear implantation for the improvement. So that's a surgical procedure whenever the bilateral severe or profound hearing loss is there. Non-hearing conservative vestibular ablative surgery, labyrinthectomy, ablation with a hypertonic saline, transcanal, transmastoid, translabyrinthine cochleovestibular neurectomy. Thank you. With this, we come to an end of Meniere's disease. If you like my video, hit the like button and subscribe.